Good morning, everyone. So our next session is on liver diseases. So we have 4 topics to present today, and we have 3 experts in the field of hepatology who will be giving us these talks. And I'm really excited and I look forward to listening to our experts and learning from them. So our first speaker today is Dr. James Boyer. Dr. James Boyer is the Ensign Professor of Medicine and Emeritus Director of the Liver Center at Yale School of Medicine. He was the founding director of the NIH-funded Liver Center at Yale. His laboratory's major efforts have been the study of mechanisms of bile formation and cholestasis. He has also served as the president of both the American and the International Association for the Study of Liver Diseases. He is a recipient of Distinguished Achievement Awards from the AGA, AASLD, American Liver Foundation, and he also is a recipient of the European Association for the Study of Liver Diseases International Recognition Award. He's a world leader in the field of cholestatic liver diseases, and I'm very grateful that he has accepted our invitation to provide 2 talks today. His first talk is on primary biliary cholangitis, updated treatment paradigm. Thank you, Dr. Boyer.
Thank you for that very generous introduction, Dr. Murali, and good morning, everybody. Primary biliary cholangitis, as you all know, is a chronic progressive cholestatic non-suppurative disease that's found primarily in the northern hemispheres and around toxic waste sites in England, around coal mining areas, exposure to cobalt, suggesting that the disease has both a environmental as well as a genetic disorder. This is the florid duct lesion that you're familiar with is the early manifestation histologically of PBC. The natural history of this disorder, it can be very variable, but usually it's over 20 or 30 years before it's progressed without therapy. If the patients present with symptoms, they have a shorter natural history than they do if they present without symptoms. But eventually those patients will progress to end-stage liver disease as well without therapy. The diagnosis of PBC now is made on 2 of these 3 characteristics: an elevated alkaline phosphatase, a positive AMA that has to be a titer greater than 140, or a liver biopsy. Today, we seldom need to use a liver biopsy and rely on the biochemical measurements. Now, until the last 6 months, this was the paradigm of treatment for PBC once the diagnosis was made. You would start the patient on primary therapy with ursodeoxycholic acid at a dose of 13 to 15 milligrams a day. You would then test the biochemical response at 6 months or a year. And if the alkaline phosphatase was not less than 1.67 upper limit of normal and the bilirubin did not remain normal, you would consider alternative therapy. And the only FDA-approved alternative therapy until 6 months ago was oxalic acid, OCA. If the patients made that biochemical response, you would continue on ursodiol. But now, that is no longer the case. First of all, the FDA has not approved the drug for continued therapy, and you would consider an alternative drug, such as one of the new PPAR alpha agonists that we'll talk about, or fenofibrate, which is available off-label, and or in Europe, bezafibrate is the drug that's usually used. So I'm going to spend the rest of the time talking about these current and emerging therapies and some of the abstracts that came from the AASLD meeting on this topic. First, this is just to remind you of the fact that a very large multi-center study of almost 4,000 patients clearly indicates that UDCA is associated with prolonged liver transplantation-free survival, irrespective of sex, age or disease stage. The survival benefit of these patients remains statistically significant with an incomplete biochemical response to urso acid therapy, as shown in the right panel here. So urso is here to stay. The new therapies, of course, are elafibranor, cilaterpar, who've just been approved by the FDA for second-line therapy, and ongoing trials with IBAT inhibitors and other drugs such as this NOX inhibitor. There are other drug candidates in trial as well. The FGA19 mimetics, which inhibit bile acid synthesis, the IBATs, the ileosodium-dependent bile acid transporter inhibitors, such as maralixabat and linarixabat. Cycloflexar is no longer available now in trial because of futility. And, of course, the fibrates, fenofibrate, bezafibrate, and the other PPAR agonists, as I mentioned. Now, I want to tell you a little bit about this receptor that these agonists interact with. There are 3 different PPAR receptors: an alpha receptor, a delta receptor, and a gamma receptor. The different compounds interact with these different receptors. Bezafibrate interacts with all 3 of the receptors. Sanofibrate interacts with an alpha receptor. Cilaterpar is a delta receptor agonist, and elafibranor is an alpha delta receptor agonist, whereas saraglitazar is a gamma interaction. Now, whether there's any difference in the interaction with those receptors is really not clear, and the data I will show you, I think, will emphasize that. Now, the POISE criteria was the primary endpoints at 12 months that all of the major trials have held. That's the kind of composite of the alkaline phosphatase, less than 1.67 times upper limit normal, with an alkaline phosphatase reduction of at least 15% from baseline at start of trial, and a normal bilirubin. And this is the data published recently in the New England Journal for elafibranor. And you can see the biochemical response. That's the composite POISE criteria. Went up at 15, 26, 39, to 52 weeks. Its significance of 51% of patients compared to the placebo of 4%. Normalization of alkaline phosphatase continued over time, as you can see here. This trial did not, using the NRS score for measuring pruritus, that is how intense the pruritus is over a 10-point score on a daily basis, did not meet significance at that 52 weeks, and this is the percentage change in alkaline phosphatase. Compared to the trial of cilaterpar, which had a composite response of the POISE criteria of 61%, 62%, but as you'll notice, the placebo was 20%, so when you reduce that, it's more like a 40% change. 25% normalized the alkaline phosphatase at the end of a year. Pruritus, the NRS score was significant, although barely so, at 12 months, and this is the alkaline phosphatase change. Now, at the AASLD 2 weeks ago, there were a number of abstracts that continued to examine the performance of these 2 drugs and the open label extension period. And on your left, you see with elafibranor, after 2 years and 3 years, the composite endpoint reached 85%, and normalization reached 30 of alkaline phosphatase reached 39%. Also, the liver stiffness measurement and the ELF score tended to show stability from the baseline to 2 to 3 years. In addition, when they did a sub-analysis of the phase 3 trial, they noticed that there was efficacy in patients with cirrhosis as well as patients, this is cirrhosis that's not decompensated, the increase in alk-phos, the SGGT, and the alkaline phosphatase, as you can see here. So the bottom line here is that elafibranor produced a consistent treatment effect across disease states. This is another abstract, a light-breaking abstract, 5041, where you can see that now elafibranor does show significant changes in the NRS score over 3 years, another score, PBC-40 itch, and the 5D itch. So in contrast to the 12-month period, you're now seeing an effect on pruritus. Seladelpar, over the same period of extension of these, you can see there's not too much increase in the composite response, that is the Boy's criteria. After 30 months, almost 3 years, it's now at 80%. Not too much further increase in alkaline phosphatase. Let's just go back and you can see this is 81% and 41% compared to 85% and 39%. So very, very similar after 3 years in these composite endpoints and normalization of alkaline phosphatase. And like elafibranor, in a subgroup analysis, it was shown that the patients with cirrhosis, compensated cirrhosis, also had a strong safety record and was well tolerated in patients with compensated cirrhosis. The new guy on the block is volixabat. This is one of the IBAT inhibitors. There are many now in use in the pediatric age group for the pediatric symptoms of pruritus. And this is a 16-week interim analysis of this study, where they have 2 doses, 20 milligrams and 80 milligrams, randomized 1-to-1 in patients with PBC. And you can see over on the right that both the 20 milligram and the 50 milligram dose of volixabat were quite effective, led to significant reductions in PBC after 16 weeks. So the 20 milligram dose, BID dose, has been chosen for the further extension of the Part 2 Advantage trial for volixabat. These IBAT inhibitors are effective, I believe, because they're depleting the bile acid pool size in the liver, and that reduces the stimulus for inflammation, and I think we're going to see much more of these drugs because they have a totally different mechanism of action than does do the PPAR agonists. Finally, I'd like to just conclude with a brief comment on the treatment of pruritus in chronic cholestasis. If the patient has very mild pruritus, you might give them a histamine blocker like hydroxyzine, and I usually give it in the evening so that they're not drowsy during the day. Bile acid binding resins remain the initial primary drug to try. Cholestyramine, which is a powder, as you know, or cholestipol, which is pills. You have to disguise this resin in orange juice or apple juice or something of that sort. You need to give at least 4 grams 20 minutes before each meal, in contrast to what the package insert says, which is with meals. It doesn't work very well unless it gets down into the duodenum before your meal stimulates the bile flow and contraction of the gallbladder. So 20 minutes before each meal. If cholestyramine remains intolerable or doesn't seem to be effective for pruritus, you might try rifampin. I've not had much success with opiate antagonists or plasmapheresis or the molecular absorbent recirculation system. Those are last-ditch efforts, and remember that refractory pruritus can be an indication for a liver transplant. Finally, there are drugs now, including the bezafibrates, which unfortunately are not available in the United States, but are in Europe, and other PPAR agonists which are effective for pruritus. Here's an abstract from 2 years ago in EASL, it's now published, showing that bezafibrate is superior to placebo, improving pruritus and chronic cholestatic liver disease, both PSC and PBC, as well as other secondary sclerosing cholangitis. And you can see it was 38% of the patients had greater than 50% reduction in pruritus compared to the placebo. So these are good drugs for treatment of pruritus. And finally, the liver stiffness measurements, which I'm sure many of you are getting in your patients, has now been validated as a prognostic marker in PBC. This is a study recently published in the Clinical Gastroenterology Journal of almost over 3,000 patients with PBC and showing a correlation, no matter if the disease got worse or got better, for the primary endpoint of decompensation or transplantation or death. So the liver spleen scan has been validated here as a prognostic marker for PBC. So in summary, PBC is a major progressive chronic cholestatic disease that ultimately requires transplantation. UDCA, obeticholic acid, elafibranor, and cilaterpar are FDA-approved drugs for PBC that improve hepatic function and survival. And several alternative therapies are currently in phase 2 or 3 clinical trials, including fibrates, other PPAR agonists, and the IBAT inhibitors. Thank you very much for your attention.
Thank you so much, Dr. Boyer, for educating us on PBC. So our next speaker is Dr. Robert Gish. Dr. Robert Gish is a professor of medicine at Loma Linda University. He is also an adjunct clinical professor at the University of Nevada in Las Vegas and University of Nevada in Reno School of Medicine. He has also previously served as the medical director of liver transplantation at California Pacific Medical Center and as the director of the Center of Excellence for Hepatobiliary Disease and Abdominal Transplantation at UCSD. He has over 600 publications in various aspects of hepatology, and he's a medical director of the Hepatitis B Foundation and is a leader in the field of hepatitis B. Thus, I'm immensely happy and excited to hear his talk on chronic hepatitis B, who to treat and when to treat.
Arvind, thank you so much. Good morning, everybody. Yes, we're going to really ask you to put on your seatbelts now. We're going to accelerate through this hepatitis B disease state in 15 minutes, so I'm going to try to do my best. I have a website. I'd ask you to go and subscribe to my newsletter, and I'm on social media, interact with about 22,000 people around the world every week, and hepatitis B is definitely one of my hot topics, and there's resources on that website as well as my disclosures. So, and this slide deck has a number of hidden slides, so you can go to my website and download that afterwards as well. Message today: 2 people are dying every minute from hepatitis B. This is a failure of a number of issues, including the guidelines that have been published over the last 20 years. The guidelines have had no effect on the death rate from hepatitis B, in spite of having multiple very safe therapies, 3 of which I'll discuss in just a moment. Also, we have problems with epidemiology. The NHANES has chronically underestimated hepatitis B prevalence in the US. We think the best paper is a paper from Robert Wong and myself, who published the current prevalence for S antigen in the US to be about 2.4 million. That's been supported by more recent data from Homi Razavi, but we have a problem. This is a very infectious disease, and 2 billion people have hepatitis B in their liver today in the form of cccDNA. That is shown by a test called the core antibody test, which I'll get back to in a moment. So when you're assessing for hepatitis B, every adult should have this triple panel. And you need to interpret this triple panel correctly. Surface antigen, when positive, of course, indicates infection. And you need to test all of those patients for delta hepatitis with a delta antibody. And that delta antibody is available through Quest, ARUP, Mayo, and that will also be available through LabCorp as an antibody test and a PCR test before March of 2025. Core antibody has been terribly misinterpreted over the last 2 to 3 decades. We've been vaccinating these people. We've been claiming it's false positive. That is fake news. This is an extremely accurate test. The false positive rate is 1 in 500. So if you see core antibody, those people have been exposed. They don't need vaccine. They're at risk for reactivation. You've been hearing about all these immune modulators at your GI meeting, also in rheumatology, oncology. Those patients may need to be tested for occult hepatitis B. So core antibody is a foundational test of your triple panel. And surface antibody indicates immunity only if core antibody is negative. There's no natural immunity. There's no healthy carrier. These are all old terms that need to be phased out. Even though hepatitis B is incurable, we have something called a functional cure, which is surface antigen loss and DNA negativity. We'll talk more about that as we get into this presentation. Vaccination will ultimately help us eliminate hepatitis B globally if we can get birth dose and catch-up vaccines to everybody. Gavi recently changed their policies to get that birth dose funded in many underdeveloped countries. But that's going to take us 40 to 60 years with 2 people dying every minute. Vaccine is a long-term gain, but it's not the short-term action that you need to think about. This is hepatitis B related mortality is rising, and part of this has to do with undertesting, undertreatment, and concomitant fatty liver disease. Fatty liver plus hepatitis B has almost a 20-fold increased risk of hepatocellular carcinoma. So when you have a hepatitis B patient, assess them for alcohol use disorder, assess them for metabolic syndrome, and really think about my message, which is to treat all. We'll get back to that in a moment. Because of the guidelines being so complex, they're not harmonized with HIV. We test everybody for HIV, we treat everybody. Hepatitis C, we test everybody. They're RNA positive, we treat everybody. Hepatitis B, we have 36-page guidelines that nobody reads, nobody follows, especially in the primary care setting. This is extremely important to be making this simple. And by the end of this presentation, you're going to hear some very simple messages. Hepatitis B integrates into the host cell genome and becomes oncogenic. We'll talk more about that in a moment. There's a lot of different phases of this disease. The message here is stage every patient using non-invasive tests. Elastography, we have a number of other tests, platelet count, ELF test is now being used. Get FIB4, stage your patients who are surface antigen positive. Everybody gets a DNA level because the DNA level correlates with HCC, cirrhosis, and mortality risk. So quantitative DNA, DNA positive, I'm placing everybody on treatment. This is following the new China guidelines and close to the recent WHO guidelines. The AASLD guidelines were published in 2017 with data from 2015, so already 10 years out of date, and maybe another year before the new guidelines come out. The guidelines are going to be restricted because they have very limited what are called PICO questions. So I wouldn't depend on the new AASLD guidelines to really guide your global hepatitis B behavior. Nukes, we have TDF, TAF, and entecavir. This reduces cancer risk, liver cancer risk by 70%, can reduce cirrhosis risk in properly managed patients by over 99%. People should not be progressing if they're on a nuke if they're fully suppressed. So these medications work, they're very safe. It's time to treat everybody who's DNA positive. I'm just showing you all these guidelines around the world, ALT, fibrosis, e-antigen, DNA level. Way too complicated. These guidelines have failed. We need to make this simple like we've done for hepatitis C and HIV. And that's the only way we're going to get to the WHO elimination goals. We haven't gotten any change in 20 years in terms of the death rate or the progression rate of this because less than 5% of people globally are on treatment. So this is a long list of why we should treat everybody who's DNA positive. I've only got 8 minutes left, so I'm not going to read through this long list. Let's make it simple. Quality of life, discrimination, stigma, patient preference, engaging patients in care, cancer risk, cirrhosis risk. This is an infectious disease. Let's look at the whole patient. Hepatology has just been talking about cancer and cirrhosis for 20 years. This is not talking about the whole patient. This list really takes into account all the different issues about why a patient should be on treatment. Another word we need to get rid of is this immune tolerant word. It's an oxymoron. It's not true. There's a great paper in my textbook 2 years ago from Carla Boni on why this term is wrong. So we'll just say low inflammation, high replication state, similar to what EASL guidelines use. I quantitate surface antigen levels on every patient every year because that change in surface antigen helps you define what's happening with that patient from an immunovirologic perspective. There's also a risk level between surface antigen and cancer, surface antigen levels and infectivity. That's a whole nother hour-long discussion, but I advise you to get Quant-S annually on every patient, especially as new medications are being developed, because we're going to stratify new treatments based on surface antigen levels. This is how bad hepatitis B is. This is the equivalent of smoking a pack of cigarettes a day in terms of cancer risk. We can reduce cancer risk by over 70% by placing patients on treatment and getting HBV DNA negative. This is another slide on how bad our guidelines are and how many people fall outside the guidelines that still get cancer, because the guidelines are so strict. They want the highest level of evidence. But every day you drive your car, you stop at stoplights. There's no randomized trial of stoplights anywhere or parachutes. There's many things we do every day that are life-changing or life-savings that don't have the highest level of evidence. So we need to put the whole package together for our patients. Surface antigen clearance is great. This happens in 5% to 10% of patients on nukes. Also, stopping nukes can bring about another 5% of patients, but we need to do much better. At the end of this, I'll talk about the new therapies. Today, we've got TAF, which is my first-line treatment. I also use TDF occasionally or entecavir. TAF has the lowest rate of resistance, lowest risk of bone and renal injury, some of which we saw with TDF. Entecavir has no bone issues, has no renal issues, but entecavir does have a little higher risk of resistance and a little bit lower viral response rate than TAF. So we really have incredibly safe, effective therapies, even though functional cure isn't good. But we put people on diabetes and hypertension medicines lifelong. But I don't use lifelong anymore with hepatitis B treatment because I have all of these other benefits, and there's 65 new drugs in development for hepatitis B. Within 5 years, we're going to have a 40% functional cure rate. So don't tell your patients lifelong, tell them they're going to be on long-term therapy until newer treatments become available. Again, I just want to make sure you're not using that word lifelong. You have long-term treatment, you have great hope, new treatments coming. That's going to keep your patients much more engaged and compliant with treatment. Eventually, we're going to get to what's called complete cure or sterilizing cure. We'll be able to get rid of cccDNA. We have a lot of what I call genetic therapy and epigenetic therapies that are coming, similar to what's going on in the CRISPR world. But there's at least 4 companies looking at gene modification for cccDNA and also the ability to get rid of integrated virus. That's really going to be important, I think, to further decrease cancer risks. People who take medications feel better. Hepatitis B affects quality of life, like hepatitis C. It's an inflammatory virus. And there's also quality of life issues related to stigma, social stigma, self-stigma, discrimination, perceptions and realities of infectivity. So on treatment, people feel better. They're more engaged. They think that their provider is helping them with their life, their quality of life. This is super important. This is data-driven. I've learned a lot about stigma, including self-stigma. By treatment, we can help people return to what we call a normal self. Hepatitis B is stigmatizing. If you're in the Philippines, you have hepatitis B, you're never going to get a job with a large corporation. You're never going to go to another country to work. China, the stigmatization is so high that people refuse to get tested because they can't get a job, they can't get married. There's all sorts of other social problems in the most infected country in the world. Tenofovir decreases the number of integrations and decreases transcriptional activity of the integrants of hepatitis B. This, I think, will have a long-term benefit in terms of decreasing liver cancer risk. This is a molecular explanation for that 70% number that we have given you. So now we're suppressing, but the future is functional cure, which is S antigen loss, DNA negative, off treatment. I'm an optimist. I'm from Kansas. I really think this is going to happen in less than 5 years with what I know about the current drugs in development. People who fail that next cycle, there'll be more medications coming. So we'll be moving patients stepwise. So I'm going to make this simple. Test all adults for hepatitis B with a triple panel. Vaccinate all adults who are triple panel negative. Surface antigen positive. Get quantitative surface antigen, quantitative DNA, and check for delta, and treat everybody who's DNA positive. This is following the Chinese guidelines, which I think are the best written, the most advanced, and most evidence-based. Stage your patients and decide who needs surveillance. Screening's the first test. Surveillance is ongoing testing. The pipeline is huge. We have 65 medications that I know about in drug development heading towards this functional cure. We're going to block replication, we're going to reduce antigen, we're going to be doing immune stimulation. Yes, the next wave may be 3 or 4 drug combination. That's okay. People say, well, people don't want to get injections. Well, they do. In Vietnam today, every month, everybody in Vietnam gets an average of 2.2 injections a month for something. In Egypt, they have hyper-injection clinics. In Brooklyn, if you're in the Asian community, you don't feel good, you go in and get an IV for vitamins or electrolytes. So injection therapy is acceptable socially. Interferon may come back and be part of our next wave of treating hepatitis B. So think about hepatitis B simply, harmonize with HIV and hepatitis C, test everybody, DNA positive treat. If you're in a low-income country where a DNA test might cost $100, like what happens in Africa and some places in Central Asia, we know that 95% of surface antigen positive people are DNA positive. So in those settings, Homer Rizavi has modeled that it's cost-effective just to treat everybody who's surface antigen positive. Thank you so much for having me. Hopefully you can take a deep breath, and let's work together. Thank you, Arvind.
Thank you so much, Dr. Gish. That was almost like a Disney ride of hepatitis B. Thank you. Next, we have Dr. Laura Kulik. Dr. Laura Kulik is a professor of medicine, gastroenterology, and hepatology at Northwestern University in Chicago, Illinois. She's a leader in the field of hepatocellular carcinoma. She's an author on the AASLD practice guidelines on the prevention, diagnosis, and management of hepatocellular carcinoma. I've had the pleasure of listening to her talks previously, and I'm very thankful that she's here. I cannot think of anyone better than Dr. Kulik to provide us with an update on hepatocellular carcinoma. Thank you for being here.
Thank you so much for that kind introduction and the invitation. I was tasked with resection versus transplantation, a treatment algorithm, and this is, I'm trying to say, can be as clear as mud. I'm going to try to walk you through some of the algorithms that we have. First and foremost, these are my disclosures. A multidisciplinary care approach is very important in patients who have underlying HCC. It's been shown in multiple reports that if you are part of a multidisciplinary team that discusses your case, that there's a significant improvement in your overall survival, and up to 42% of patients will have their management changed after being discussed in a multidisciplinary care setting. And for this reason, our guidance says that patients with HCC should be discussed and managed in a multidisciplinary care setting. If you are in the community and you do not have access to this, many of the academic settings will allow you to join their multidisciplinary team where you can present your cases. So just a big plug for that. A little bit of history. So the first trials in transplantation by our godfather of transplantation, the 6 out of 7 were for cancer, either HCC, cholangiocarcinoma, or colon cancer. And they all failed. All of these 7 patients died within 3 weeks. Fortunately, we see that we do have a long-term survival. One of the oldest was done in January of 1970. So we have had a lot of progress in terms of transplant, and it took many years before we saw this progress in HCC. It wasn't until 1996 when Dr. Mazzoferro came up with the Milan criteria that the moratorium on transplantation for HCC was finally lifted. And this is 1 lesion up to 5 centimeters, 3 lesions, no one greater than 3 centimeters, no vascular invasion, and no evidence of extrahepatic spread. And with this, we have seen a great success. Patients are living 10 years up to 60%. There are tumors that are too large and tumors that are too small that I will talk about a little bit more during this talk. Shortly after the Milan criteria released, as physicians, normally we always want to push these boundaries, and we started talking about, can we downstage patients? So making it very simple, there are patients within the Milan criteria. I explained to my patients they fit into this box nicely. They're giving an upgrade for our priority for transplantation. If their tumor is beyond the Milan criteria, they are not given a priority, so we try to shove them back into the box by using things like local regional therapy and more recently systemic therapy. And if their tumor is now within Milan criteria, they are allowed to get an upgrade after a period of 6 months of waiting. And this is really a moving target. I'm not going to go through all the different factors, but we are now talking about downstaging people with portal vein invasion, which is something that we would never have considered 25 years ago. So this is the BCLC staging system. This is the most recognized and widely used in the West, and I'm going to focus on the very early and the early patients with HCC. Those who have very early, this is a single lesion, less than 2 centimeters, you will see that transplantation is not in that algorithm. It's ablation or resection. And this is because these are patients, again, these are Child-Pugh A patients. The benefit of transplantation when you have a very early tumor is not very great, and therefore it is not encouraged. These are just some of the contraindications for the potential curative options in early HCC. I'm not going to go through all of these. This is just for your edification. You can see that the 5-year survival is similar with a little bit more in liver transplantation. However, recurrence rates are significantly lower in patients who are treated with transplantation versus resection or ablation. So you may say, well, why don't we just transplant everybody who has liver cancer then if it has the best recurrence-free survival? And there's 2 reasons for this. One is we don't have enough livers to go around. Very recently, as of November of last month, over 10,000 patients were waiting for transplantation. As of last year, 59% of those listed got transplanted, 23% were removed because they were too sick, and 9% died. The other reason is you really want to concentrate on what is the transplant survival benefit, and this is looking at what is your life expectancy after transplant, with the biggest concerns being recurrence of your HCC, as well as other things that go along with immunosuppression, other cancers, diabetes, metabolic syndrome. And then what is your wait list expectancy? Patients who have a very early tumor or that you can control with ablation or Y90, there's very little benefit of transplanting those patients because you're controlling the tumor. So you really want to look at what's the overall transplant survival. So looking at hepatic resection, this is important to know that this is a single nodule and it does not matter what size it is. The larger the size, the greater vascular invasion, but people get very confused with the Milan criteria. You can have a 10-centimeter tumor and that size alone does not make it a contraindication for resection. You want to have a patient who has no clinically significant portal hypertension. This can be measured doing the hepatic venous pressure gradient, which should be less than 10. Or you can use surrogates like the presence of platelets being less than 100,000, the presence of varices or a spleen greater than 12 centimeters. These patients are going to have clinically significant portal hypertension. The bilirubin should be less than 1. And if both of those are applied, then the overall survival can approach 70%. However, if you have patients who have clinically significant portal hypertension as well as a bilirubin greater than 1, your survival rate significantly decreased. Even if you meet all these criteria, you have to make sure that the person has enough of a future liver remnant. And these are different depending on your degree of fibrosis, and it should be greater than 40% in patients who have cirrhosis. And the Achilles heel of this whole hepatic resection is the recurrence rates are up to 70% at 5 years, and it's bimodal. Usually within the first 2 years, this is micrometastatic disease, whereas beyond 2 years, generally within 5 years being the second increase, is due to the presence of ongoing cirrhosis, and this being a prerequisite for underlying HCC. This is from the SSLD. It walks you through the algorithm that if someone has an early tumor and that's a single lesion, their child's PUA, they have no evidence of portal hypertension, you would proceed with resection. However, if they had portal hypertension, more than one lesion, or they are decompensated, you would proceed with liver transplantation. However, there has been advancements in our surgical techniques, particularly minimally invasive, laparoscopic, and more recently robotic, that now we can get away with doing a little bit of portal hypertension and maybe a little bit of patients who are decompensated child's PUB7. But if you add both of those together, as was shown in this bridge study, which is over 10 years old now, you are significantly decreasing their overall survival. Recurrence, as I said, is up to 50 to 70% in 5 years with a median time of 20 months. And if you have vascular invasion on your explant, that's as short as 7.5 months. And it's very important once someone is resected that you follow these patients every 3 to 6 months, depending on how high risk their explant was. Because if you find another cancer, you could go on to transplantation, repeat resection. So looking at surgical resection, if a patient is a candidate and they have recurrence and they were within Milan criteria, if they recur within T1, so a single lesion less than 2 centimeters, if it's biopsy proven, they are a candidate for an upgrade without having to wait 6 months. If they're within T2, which is synonymous with Milan, they are able to get an upgrade immediately without having to wait and undergo a salvage transplant. If they're greater than Milan criteria at the time of recurrence, then they will need to be downstaged. And there are the UNOS downstaging criteria, which I've highlighted in the purple box. If they are downstage, then they are able to get an upgrade after waiting for 6 months. What if a patient is a candidate for resection, but they don't have an adequate future liver remnant? Now, there are 2 ways that you can deal with this. One of the older ways is doing portal vein embolization. This is much quicker. However, the concern is you are leaving the tumor untreated and you're growing the opposite side of the liver. What is being done more is using the use of TAR or radioembolization or Y90, where you treat the underlying cancer as well as grow the opposite side of the liver with radiation, but this tends to be a slower process, and these patients can then get to resection. What about the algorithm for transplantation? If patients are within the Milan criteria, they must have an AFP at the time of listing less than 1,000. Many patients undergo bridge therapy. It's approaching over 90% at this point in time. They get listed, they wait 6 months, and after 6 months, if they are still within Milan criteria, their AFP is now less than 500. They are given a MELD upgrade, which is the median MELD at transplant -3. Some of those patients will go on to transplant, others will become too sick or drop out or pass away. These patients have to undergo imaging every 3 months with a CT scan, triphasic, or an MRI with contrast, a CT of the chest to look for metastatic disease, and markers for cancer such as AFP. We're also using AFP, L3, and DCP every 3 months. What if they're outside the Milan criteria? You can successfully downstage these patients using the UNOS downstaging criteria. There's something called all comers, where there is no restriction on size and numbers. Those patients can be attempted to be downstaged. They're less likely to achieve this, and they need to undergo a review board by a national review process to say if they are candidates for listing with a MELD upgrade. There's a lot of things that we've learned from downstaging. I think the most important thing is it works. You can take patients who are outside the Milan criteria, give them local regional therapy, and get them to transplant. AFPL3 was one of the most predictive in terms of risk of dropout. 43% in a multi-center trial showed that they were understaged. This highlights the importance of trying to treat with local regional therapy to the point of no enhancement, while simultaneously not over-treating to lead to decompensation. There has been a randomized controlled trial. I think it's apropos that it was Mazzo-Ferra who did this. I don't think we could do this in the United States. Patients who are outside the Milan criteria were treated with local regional therapy. There were some with sorafenib. Those who were successfully treated were then randomized to go on the transplant list versus continued on-demand local regional therapy. And not a huge surprise, patients who underwent transplantation had a significant improvement in recurrence-free survival as well as overall survival. So we do have level 1 data for transplantation. We unfortunately do not have level 1 data, and I don't anticipate that we ever will for resection versus transplantation. This is the most recent meta-analysis where it looked at the comparison of patients who underwent transplantation versus those who underwent resection and looked at the endpoints of overall survival and recurrence-free survival. This was close to 20,000 patients that were in this trial. The patients who underwent resection tended to be older and tended to have less underlying cirrhosis. What did they find? Overall, there was a significant improvement in overall survival in patients who were transplanted, as well as an improvement in disease-free survival. When you looked at where this occurred in the East versus the West, in the East, overall survival was not different. This is probably because they do a lot more resections. There's more hepatitis B, so less cirrhosis, so they're less likely to die of their underlying cirrhosis, as opposed to in the West. But when they looked at patients who had unilobar disease, there was no significant improvement in overall survival with transplant, but disease-free survival was significantly improved with patients who underwent transplantation, to the point that there was a 3 times increase in HCC recurrence in those who underwent resection compared to transplantation. So really a big plug for undergoing transplantation. We just heard an excellent talk by Dr. Gish. I will say that when I see patients with hepatitis B, they're in this continuum of S3, and they tend to have high AFP, more vascular invasion. We resect them because we can. We then transplant them, and you just see them keep recurring. Will that change as we start to be more aggressive with therapy? Hopefully. But in Hep B patients, who are usually more the ones that we can resect because their portal hypertension is not so great, I tend to focus more on the potential of transplant for that reason. Very briefly, how have things changed in this immunotherapy era? These are just some of the immunotherapies. I will tell you that monotherapy TKIs is no longer the first treatment option. It is still considered first line, but it should not be used unless someone is not a candidate for checkpoint inhibition. Here we see the STRIDE regimen and the IM-Brave 150 regimen. The Checkmate D9DW PDUFA date is sometime in April of this year, and suspect that this will move up to be frontline with dual checkpoint inhibition. This is looking at people who have undergone resection, and this was looking at the use of atezo and bev in patients who had a resection. Patients were randomized to just following them versus putting them on atezo bev in the hopes of decreasing recurrence. You can see early on in the lower panel that the curves did separate out. This was endorsed by SSLD to use this for patients to try to decrease recurrence. However, very recently, unfortunately, there was a follow-up and these curves came together, and therefore this is currently no longer being endorsed to do adjuvant therapy after resection. What about neoadjuvant therapy? It's currently not endorsed, but we're seeing more and more studies that are coming out. It makes a lot more sense. You're training the immune system while the tumor is still in place, as opposed to waiting to give them immunotherapy after the tumor has been resected. So more to come on this. This is a very nice article that just came out, a review article on transplantation, highlighting all the barriers and the things that we need to talk to patients about. And again, going back to this transplant-free survival notion, the biggest concern is HCC recurrence, comorbidities, complications of immunosuppression, and we can overcome or try to mitigate some of these by using calculators called the retreat calculators, probably the most common, and how we should screen patients after they've been transplanted, because if they have a recurrence, it's a single recurrence, resecting that can lead to improvement in overall survival. Close intervention to minimize immunosuppression, cancer screening, and weight loss therapy. In terms of patients who are at higher risk of dropping out because of progression, we now have immunotherapy. There's also concerns for patients who are too sick or frail. There's prehab, treating their Hep C, treating their Hep B. We're using organs now that are deceased cardiac. We have machine perfusions, the increased use of living donor as well. Just briefly want to talk about this whole notion of frailty. It is a big problem after transplant. It leads to longer hospitalizations, delayed initiation of physical therapy. It's much more expensive. And this was a trial looking at liver resection, where you also see there's a significant disadvantage in patients who are frail. They're more likely to have a more aggressive tumor with higher AFPs, poorly differentiated, and more likely to have recurrence that occurs outside the liver, which is the worst prognosis. And sarcopenia may be leading to the immunosuppression in the immune system not being able to control control the tumor. It's also been shown that these patients respond less robustly to immunotherapy as well. And this is just to highlight that immunotherapy with the target of getting people to transplant, we are in this period. Before we were doing accidental transplants. Patients got immunotherapy, we saw a remarkable response and said, why don't we transplant them? Now we are purposely giving immunotherapy to get patients to transplantation in combination with local therapy, usually after they have not had a robust response or a complete response. So more to come on this. And then what about patients who are not a candidate for resection or transplantation? We see ablation here. I just wanted to briefly mention that there is the use of radioembolization that is being used in an ablative fashion. So this is very high dose radioembolization to 1 to 2 segments of the liver. And what we found is that this achieves overall survivals that are very similar to what we see in patients who undergo transplantation or resection, particularly in those with a lesion less than 3 centimeters, leading Dr. Lewandowski, who I work with, to conclude that this is a very attainable treatment option for patients who are not candidates for resection or transplantation. And so these are my takeaway points. The decision between resection and transplantation is complex. It should be individualized. You do need a multidisciplinary team to have the best outcome. Resection leads to high recurrence rates. They require close monitoring. And transplant oncology is rapidly changing due to the scene of immunotherapy as well as advancements in the surgical techniques. And these are my 2 French bulldogs, Miles and Davis, who are the loves of my life. Thank you very much.
Thank you so much, Dr. Kulik, for the talk. Our last talk on the liver session is again by Dr. Boyer, and this is on primary sclerosing cholangitis, challenges in diagnosis and management.
Well, unlike the situation with primary biliary cholangitis, we have no therapy for PSC, and we really don't understand its pathogenesis. So I'm going to focus on these challenges in diagnosis and what I think you should be doing with your patients. So this is a Netter's drawing of this disease. One of the problems with this disease is a fibrotic disease rather than inflammatory disease, and it's quite highly heterogeneous. It's also low prevalence, 1 or 2 per 100,000, and this makes it very difficult to do trials. Here you see the major stricture within the common bile duct, as well as with the interhepatic tree. And one can have variations of this, of course. 2/3 of the patients, roughly, are associated with inflammatory bowel disease. The others are not. And there are other variants like IgG4 diseases you don't want to miss because that's treatable with steroids. So PSC is a chronic non-suppurative cholestatic disorder of both the intrahepatic and extrahepatic ducts. It's a radiologic diagnosis here, either by ERC or P or MRCP, and we prefer MRCP obviously because it doesn't introduce infection. The etiology, as I said, is unknown. It's thought to be one of the immune disorders, but does not really respond to immunosuppressive agents. P-ANCA can be positive, and 5% of ulcerative colitis patients can develop PSC. The tragedy of this disorder is the development of cholangiocarcinoma, and this can occur as high as 5 to 10% in PSC. The typical radiologic appearance on the left, this was old study with MRCP. And then there's the variant of small duct PSC, shown on the right, where the radiologic studies are completely normal, and one has to revert to a liver biopsy to demonstrate that. But here's the typical picture of PSC with major circulating onion skinning of the major bile ducts, leading to destruction of the biliary epithelium with time. Now, as I said, we don't know very much about the pathogenesis of PSC, but there are lots of theories about it, which are nicely illustrated here by my colleague David Assis and Chris Bolus in this recent study here. We know that the gut is different in terms of bacterial flora. There's dysbiosis, there's a reduction in the number of species. There is evidence that Klebsiella species and perhaps Eficalis may be associated with PSC. But in a leaky gut, there seems to be ideas of translocation of bacteria, and that's triggering an innate and an adaptive immune response. This leads to dysfunction of the cholangiocytes, bile duct injury, proliferation, senescence, and ultimately the stimulation of fibrous tissue in the peribiliary myoplast activations. As I said, cancer is a real problem with PSC. 50% of cholangiocarcinomas can be diagnosed in the first year after diagnosis. This is a Mayo Clinic recommendation, and I think that's primarily because of late disease is late of that. We do not see this. Patients usually take 5 to 10 years to develop cholangiocarcinoma in our clinic. The diagnosis, as I said, is difficult. One needs to take annual MRCPs as well as tumor markers with the CA19-9. If there's a dominant stricture, then fluorescence in situ hybridization or FISH may have some added value to brush cytology. Though dysplasia in a setting of the dominant stricture is not diagnosis, these patients should be referred for a transplant center. And there's also risk of other cancers, particularly colon cancer. This is a recommendation for screening by Tom Carlson in a major review. There's no basic evidence for this, but this is his recommendation that every 6 to 12 months you undertake this review with blood tests, tumor markers, ultrasound or MRI, MRCP if there is cirrhosis, an ultrasound and alpha-fetoprotein every 6 months. If there's a malignant structure or a mass, then one undertakes ERCP or with a brush cytology and FISH, and then as Laura mentioned in her nice review, you need a tumor group to view the situation. A histologic diagnosis is not always used and can be contraindicated. You have to remember that if you do biopsy cholangiocarcinoma, you track tumor through the rest of the tissue, then transplantation is prohibited. The treatment guidelines are all over the place with PSC. ESAL and ASLD disagree about the role of ursodeoxycholic acid. EASL recommends it in 15 milligram per kilogram doses. The ASLD is in the process of revising their guidelines, but they have, again, based on the fact that high dose urso, that is 25 to 30 milligrams per kilogram, is associated with adverse outcomes such as cirrhosis, varices, cancer, and liver death, some feel it should not be used. But in 15 milligrams per kilogram per dose, you're perfectly fine, and it can be effective in lowering the alkaline phosphatase. But as this study shows here, there's no correlation with the response to PSC, whether or not they're taking UDCA. There are good responders with and without CDA, and poor responders with and without UDCA. So there's no evidence that UDCA alters natural history. Now this slide I'm not going to go through, just to emphasize the fact that many agents have been tried and failed or found not to be of any use. The ongoing clinical trials for PSC are listed here, and this includes the use of sulfasalazine. There's a phase 3 trial from the Mayo Clinic with vancomycin have been previous phase 2 trials. CM101 is an monoclonal antibody to the cytokine CCL24. I have more to say about that. We're awaiting the phase 3 results of the deoxycholic acid, which I'll talk a little more about. And there's the PPAR agonist, elafibranor, bezafibrate. And then a new drug in trial, which I'll mention in a few minutes, and that's bexotegrast. Now, this is 24-nor-ursodeoxycholic acid. This is ursocholic acid with a carbon removed from the side chain, and that changes the properties of UDCA so that it undergoes an enterocolic, hepatocholic recirculation with stimulation of bile flow and bicarbonate secretion, which protects the biliary epithelium from protonated bile acids diffusing back into the biliary system. That's thought to be the mechanism. The phase 2 trials for nor-urso were published some time ago. Here you see the end results of this trial with the higher dose of nor-urso having a significant change in the alkaline phosphatase and meeting the primary endpoint for this phase 2 trial. And we urgently await the completion of the phase 2 trial with this drug. We're told that it's sometime this year, but the year is almost over now, and we haven't seen any data yet. This drug, I think, deserves our attention. This is bexotegrast from Pliant Company. It has to do with the integrin inhibitors. The alpha VB6 and the alpha VB1 integrin are inhibited by this drug. They retain TGF-beta, which is the primary fibrogenic cytokine, as you know, in extracellular matrix, and then activate it so that TGF-beta is released and go through the SMAD pathways to produce pro-fibrotic outcome. Inhibitors of these integrins prevents that happening. This is a drug that's also been used and developed for primary pulmonary fibrosis. This is some early release data from the company in July of this year. This is the liver stiffness measurements at week 24. You can see there's some improvement in the 320 milligram versus the placebo, where there is further suppression. This is the same seen for the alkaline phosphatase. Some mild improvement with the drug as opposed to the placebos at week 12 and 24. I'm not going to go through this trial. This was poster 504, late-breaking abstract at the ASLD meetings, but I just wanted to show it because one of the endpoints for this drug was the MRI time of arrival into the common bile duct, the compound gaxoidolate. And you can see here at week 12, there's a 22-second improvement, and at week 24, 113-second improvement, suggesting that bile secretion was stimulated by this drug, and one needs to keep an eye on this drug. So in summary, for the bexotegrast, it's 320 milligrams was well tolerated, up to 40 weeks actually, with no treatment-related severe or serious side effects. It demonstrated improvement in liver stiffness by transient elastography at week 24 compared to placebo. Statistically significant improvement in alkaline phosphatase over 24 weeks compared to placebo, and continued improvement in hepatic function as manifested by bile flow with contrast MRI imaging from week 12 to week 24. This is the only company that's using that measurement in these phase 3 trials. I want to come back to talk a little bit in the end here about fibrates, because there is a small study now 4 or 5 years old that the fibrates improved biochemistries in patients with PSC with incomplete response to UDC. This is a French and Spanish study. There were 14 patients with enofibrate and 6 with bezafibrate, and they had improvement in liver function tests, as you can see here. And this is the alkaline phosphatase on URSO for over 6 months, as done by most trials, and reductions in the alkaline phosphatase with a combination of fibrates and UDCA, and then the response when the drug is stopped. In addition, all the patients had an improvement in pruritus, quite significant. So adjunct fibrates significantly reduce serum alkaline phosphatase, ALT levels, and reduce pruritus in patients with PSC in this small study. And why might fibrates work? Well, they hit various pathways. First of all, they stimulate the production of phosphatidylethanol transporter, MDR3. This increases biliary phospholipid choline excretion in the bile and helps micelize the hydrophobic bile acids. Secondly, they inhibit the synthesis of bile acids through the NH4 pathway and the rate-limiting step in conversion of cholesterol to bile salts, CYP7A1, so they reduce bile acid synthesis. And thirdly, they inhibit the inflammatory pathway via MFKB, reducing TNF-alpha, IL-6, and IL-1 beta, and so overall having an anti-inflammatory effect. So it's these pluripotential pathways. In addition, there's a more recent one that our own group has been studying, and that is the glucuronidation of bile acids in the liver through uridine 5-diphosphoglucuronidase transferase, or UGT. This catalyzes glucuronidation of primary bile acids from a 3,6 or 24 glucuronide to form the 3,6 or 24 glucuronide. These bile acid glucuronides are excreted either normally by MRP2, which is at the canalicular membrane, or importantly in cholestatic disease by MRP3 or 4, which is on the basolateral membrane, so that the bile acid glucuronides are transported into the blood and out through the urinary tract. As shown here in pink studies, there are 4 or 5 different isoforms of UGT that are all stimulated by PPAR agonists. So this, we think, is why this drug is one of the other reasons this drug is effective in cholestatic disease. Let me turn to CM101. This is an interesting new player here, anti-monoclonal antibody to cytokine CCL24. This improved fibrosis markers in this phase 2 study, abstract 5005. As you can see, this is liver stiffness measurements, and the 10 milligram and 20 milligram dose improved liver stiffness as opposed to increase in the placebo group. And here, using the ELF score, which is a serum marker of fibrosis, you can see that compared to the gray placebo group, the higher 20 milligram was statistically significantly different. So this is again another drug to keep an eye on. So in summary, PSC is a progressive chronic heterogenic cholestatic disorder that ultimately require liver transplantation. Neither the cause or the treatment of the disease is known. UDCA and fibrates may be effective in improving LFTs, but whether the long-term survival is affected, we don't know. There are several interesting alternative therapies currently in phase 2 or 3 clinical trials, and these include the fibrates, nor-ursodeoxycholic acid, integrin inhibitors, and CM101 monoclonal antibody, and the IBAT inhibitors, as I showed you for PBC talk. So hopefully in the next 1 or 2 years, we might have the first FDA-approved drug for PSC, but that still remains. Thank you very much for your attention.
Thank you so much, Dr. Boyer. We will now have case presentations and discussion in hepatology. The goal of these cases is to get the opinion from our experts and learn from their experiences. So our first case, it is a 48-year-old woman referred for chronic elevation in liver enzymes. Over the last 6 years, her ALP had ranged from 220 to 392, ALT from 121 to 277, AST from 85 to 174. Her total bilirubin ranged between 1.2 to 1.6. She had significant pruritus. She was not on any medications except vitamin D supplements. AMA was negative. ANA, anti-smooth muscle antibody, LKM antibody was negative. Serum IgG, IgM, normal. Chronic liver disease workup was unremarkable. She had an MRI and MRCP that was unremarkable. So what is the next step in the management of this patient? And the audience can poll to this question. Fantastic. To our experts, do you agree with proceeding with the liver biopsy? Dr. Boyer?
Probably are going to need to look at liver biopsy, but no hard cholestyramine. Patient's itching, right?
Yep.
These are the symptoms of this.
Got it. So she did get a liver biopsy, and the liver biopsy showed mild bile duct injury, bile ductular proliferation. There was focal ductular cholestasis. There was also evidence of ductopenia. There was hepatocellular cholestasis and cholate stasis. But there was no florid duct lesions, no periductal fibrosis, or fibroobliterative duct lesions to suggest PBC or PSC. There was minimal chronic portal inflammation with the lymphocytes, scattered neutrophils, occasional plasma cells, and no interface activity. There was bridging fibrosis on liver biopsy.
Can I ask you a question? I have 4 questions. Do we have a GGT? Do we have a direct bilirubin? Do we have a sprue panel? And I'm thinking this may be small duct PSCs, but I'm also wanting an IgG4. I know you saw the IgG was normal. Do we have any of that data?
Yes, we have all those data. GGT was elevated. Celiac panel, sprue panel was negative. We also did a GP210 and SP100. Both of them were negative. We also did a cholestatic gene panel that was negative for mutations for PFIC or other cholestatic disorders. Her bile acids were greater than 300.
One more question, Arvind. In this genetic panel, they checked for 77 different polymorphisms. What were the other polymorphisms? PFIC's just 11, right?
Correct. So among all the other polymorphisms that were reported, none of them were considered to be pathogenic variant. There was one that was heterozygous for Gilbert syndrome, but nothing else was positive in the panel.
I will tell you that report, because I've ordered it on over 35 patients, is nearly worthless. You actually have to do your own homework, whether it's a PEX10 or cystic fibrosis. There's a whole variety of mutations on there that they call unknown significance or not significant, but the report is wrong.
Got it.
As we would recommend in a case like this, a genome-wide analysis. Kind of miss variants, you're going to other cholestatic disorders.
Huge number.
So how would you proceed with this case? So we started this patient on ursodiol.
Urso, of course.
Yep. So ursodiol is
I
first line.
put the patient on fenofibrate, but as I said, I would do a genome.
Got it. So whole genome analysis. So patient has been referred to a dietitian for a geneticist specialist for whole genome analysis and sequencing. In the meantime, we started her on ursodiol at 15 milligram per kilogram per day. Her alkaline phosphatase improved from 359 prior to initiation of treatment to about 200 at 3 months of treatment. But over the next 12 months, it just ranged between 200 to 250. The AST and ALT improved, but they did not normalize. They ranged from 48 to 104. Total bilirubin normalized, direct bilirubin normalized. Her pruritus actually completely resolved at 3 months of follow-up. Her bile acids improved from over 300 to 72 with ursodiol. Fibroscan at 12 months showed F3 fibrosis.
By the way, we should have mentioned earlier that you want to, of course, exclude drugs in a patient like this.
Absolutely. She was not on any herbal supplements. The only medication she was taking was vitamin D.
What was the sprue workup? Do you have a sprue panel or biopsy?
We have biopsies of the small bowel, and we have the usual TTG, IgA, anti-endomysial antibodies.
What about the IgG4?
Yes, her IgG4, entire subclasses and IgG4 level, her level was actually 62, IgG4.
62 is normal for your lab?
Yes, correct.
And her IgG was normal, right?
Correct. Her IgG was normal.
Doesn't apply to this patient, given that there's chronicity, but in someone like this where you're seeing ductopenia and nothing else is coming out positive, if it was more acute, and particularly if there were granulomas, you'd want to make sure to rule out a lymphoma causing a loss of
And
bile ducts.
sarcoid also. Sarcoid would be...
Sarcoid, yeah.
Yeah, sarcoidosis was actually considered. We did a CT chest, ACE level. ACE level was negative. CT chest did not show any lymphadenopathy.
But I agree with you about lymphoma. I've seen several patients.
So the question I have for this patient, right, she has F3 fibrosis. We have done this extensive workup. And my main concern is progression to cirrhosis and hepatic decompensation. With all the data that we have on chronic cholestatic liver diseases, is there anything else that you would use for this patient in addition to ursodiol?
Well, I would have, as I said earlier, I would have also added fenofibrate to ursodiol.
Fenofibrate.
My question to Dr. Boyer would be, have trouble from an insurance standpoint getting some of the newer drugs with everything being negative?
That's one of the reasons that I am emphasizing. And what I didn't mention is we have a abstract submitted to the EASL meeting, 3 other centers in Europe, as well as our own in PSC. 30% of the patients was within 6 months.
Mike?
Speaker.
The ones in Europe were on bezafibrate, ours, which is not available, unfortunately, in the United States. Ours were on fenofibrate. There's no difference between the 2 drugs. They're equally effective. So within 6 months, 30% normalization.
But when you look it up still in whatever pharmacology, there is still a box warning for patients for fibrate if they have underlying liver disease. Makes everybody, especially if the patient looks at it. So are you worried about if their enzymes were still elevated, putting them on fenofibrate?
It depends on what level they are. If they're only a couple of times in the upper limit of normal, I'm not really worried about. But that's an old warning from clofibrate. Nobody uses that.
Saw a patient whose ALT was 600 and they put him on.
Comment about fenofibrate also. The real-world data at AASLD showed 20% of patients had to come off fenofibrate due to liver toxicity or renal toxicity. There's also a variety of GI effects. David Jones has very much emphasized that in Europe, where bezafibrate's given out like candy, that there's also a 20 to 25% dropout rate, same as what you see with obeticholic acid. I've used OCA, and I'm not saying use OCA in this patient, but I've used OCA in over 70 patients. I've only had 1 toxicity event. So I think OCA is safer than the fibrates. Another comment on fibrates, you can get bezafibrate from Canada. I've actually brought it in from Canada for multiple patients. It's very inexpensive. You write a script, you fax it to canadianpharmacy.com. They'll have the bezafibrate. I think beza is safer than fenofibrate in the real world setting also.
Yeah, the creatinine issue is easily taken care of because that's a dose reversible complication.
Okay, so maybe try fenofibrate, but monitor for hepatotoxicity. Okay, sounds good. Thank you. Let's move on to our second case. It's a 32-year-old woman with chronic hepatitis B infection. Persistently normal liver enzymes. The ALT range was 12 to 20. AST range is 10 to 18 over a 2-year period. Hepatitis B E antigen negative. Hepatitis B viral load at 3 to 6 month intervals over a 2-year period were 8,700, 14,100, 2,780, and 7,450 copies. FibroScan showed F0 to F1 fibrosis. She had it in 2022 and 2024. So question would be, would you recommend antiviral therapy for chronic hepatitis B? And this question is for the audience. So, Dr. Gish, I know your answer. It is yes. And the question I have for you will be, so in young patients, 18 to 30, right? And you're going to start them on hepatitis B treatment. And do you have concerns that if they stop their treatment and you're not aware of it, will they have reactivation of hepatitis B? Can they develop severe acute liver injury?
Fantastic question. The ReTRAC-B data was just presented again at ASLD, but Harry Janssen and his team have been showing this follow-up data. 1,500 patients who came off therapy, stopping therapy, who were monitored for severe flare, potential fatal event. Out of 1,500, there were 3 patients who had abnormalities in liver function. Arvind, I want to compliment you for calling them liver enzymes, not LFTs, right? So a number of patients had changes in enzymes, but only 3, that's 1 out of 500 risk of having a potential life-threatening event from stopping a nuke. This paranoia about people living off anecdotes is far overrepresentative. In the Hepatitis B Foundation, we've done surveys, and 40% of patients are non-compliant with their nukes for a variety of reasons. Might be money, apathy, provider apathy. And if we had this problem with flares and deaths, every transplant center would be busy transplanting flares of B. It's not reality. So I tell patients there's a risk, 1 in 500, of coming off and having a severe flare.
In that study, did they look at surface antigen levels, or was it just the viral load of Hep B that they were monitoring?
They weren't proactively looking at surface antigen every 3 months, but they were looking at enzymes, function, and DNA. ReTRAC-B, fantastic study.
Dr. Gish, could I ask you, just to clarify, you indicated anybody with a positive HBV DNA should be treated at any level?
Any DNA positivity has a risk of infection, risk of progressive disease.
Not over 200 or 2,000, any level?
Any DNA level. That follows the Chinese guidelines published in 2002. In 2022, if you need a copy, we have data to support this. It's cost effective. It's not necessarily cost savings yet, depends on the country, but it has many reasons to treat these individuals. And let's make it simple.
And the new guidelines, you think, will recommend that?
I think the new guidelines will be out of date when they're published. They are given a limited budget. They're supposed to only answer a certain number of PICO questions. It's not going to address the patient. And just look back at guidelines over the last 2 decades. How often is the patient voice included? How often is discrimination, stigma, quality of life included? We're a bunch of hepatologists. We think cirrhosis and cancer, cirrhosis, cancer. We're not thinking about the patient. It's time to have the patient-centered approach.
And a related question. So studies have shown, and I have seen patients less than 40 years of age can develop hepatocellular carcinoma.
Of course.
So the guidelines also recommend cancer screening after age 40, but I screen for cancer even as soon as I see them for hepatitis B. So would you recommend that?
Well, the whole question is about when to start surveillance, right? Everybody gets screened, everybody gets a baseline ultrasound, but starting the surveillance process is based on surface antigen, DNA, family history, biomarkers, right? Laura just talked about this triple panel, which I've been using for over 15 years. So there's a lot of factors that would come into that. If I've got a young black Haitian patient, I've got a lot of Haitian patients in San Diego right now, I'm starting them on surveillance as soon as I see them. But if I have an older Chinese woman who's got F1 fibrosis, I might not start surveillance till they're 50, provided their triple panel, liver cancer triple panel is negative, and they don't have fatty liver, and they're not drinking, no family history. So it's a little complicated to decide on a surveillance strategy. Laura's ready.
So the double cell D, I don't I was part of those guidance, but I don't think many people practice that way. I'm not even sure Amit Singhal does, but the Page B score, which takes into account people who are on hepatitis B therapy, looks at 3 very easy factors: your gender, your age, and your platelet count, and it gives you a score. And if you are less than 9, the guidance suggests that it hasn't been looked at, therefore you shouldn't screen them. I don't ascribe to that. I think most hepatologists are still screening patients even if their Page B score is less than 9.
Okay, fantastic. Because the one patient you don't screen at 35 comes to your clinic with hepatocellular carcinoma. So having seen that, I think with hepatitis B and HCC risk, it's important to screen those patients. Last case, case 3, is a 58-year-old male, alcoholic cirrhosis, noted to have 3.2 centimeter hepatocellular carcinoma, LIRADS 5 on imaging, child PU class A, no portal hypertension, platelet count is 192, no splenomegaly on imaging, no metastasis or vascular invasion, he has no cardiopulmonary comorbidities. He quit alcohol 1 year prior to diagnosis, and the hepatocellular carcinoma was diagnosed during surveillance. How would you treat this patient's HCC? Liver transplantation, surgical resection, microwave ablation, or radioembolization? And the question to the audience. Dr. Kulik?
So this is a patient who's 58, well compensated. The cause of their liver disease has been eliminated. They've stopped drinking. Alcohol actually carries less of a risk of developing HCC than, say, MASH, which is, or MAFL, or whatever term you're using these days, which is now the #1 cause of HCC. So I would vote for resecting this patient, but I'd want to know where it's located. If it's straddling, in between, it's right near the hilum, it may be difficult. So radioembolization may also be a good strategy. Microwave ablation, some data shows you can go up to 4 centimeters. RFA, it's been 3 centimeters. But I would, go for resection followed by potential radioembolization.
Are you using, let's say the DCP on this patient is 500. Would that change your strategy, what the biomarker pattern is?
So I want to make sure they're not on Coumadin first, because it's a vitamin K dependent, and we've seen people, they're on Coumadin that's very high, and it's because of that. That's a patient that maybe a test of time, doing radioembolization and following them and seeing if that comes down, so that you don't go through the process of a resection only for early recurrence.
And what about a metastatic workup, a super high DCP, SCT, bone scan?
So bone scan is no longer required by UNOS. So I use it if you, on the MRI, there see something in the spine or there are symptoms. It has been shown that if you have a very high AFP or portal vein invasion, those are the majority of patients who will have metastatic disease. In terms of screening for metastatic disease, if you are early, so 1 lesion that is less than 2 centimeters, you no longer need to do a chest.
So this patient was discussed at our multidisciplinary liver tumor board. We had decided to proceed with surgical resection for this patient. It was in a good location. So he did get surgical resection of the lesion. During his workup, his colonoscopy also showed an ascending colon mass. So he also had a colon mass resection at the same time. When you look at the pathology of the liver lesion, it showed a well-differentiated HCC, about 2.5 centimeter. Margins were negative. There was no lymphovascular or perineural invasion on the biopsy. The colon mass came back as tubulovillous adenoma, negative for carcinoma. All lymph nodes were negative for malignancy. Follow-up, he had no decompensation after surgery. He continued to have child PUA cirrhosis. He had MRI at 3 months, 6 months, and 12 months. That was unremarkable. His AFP was normal. Unfortunately, the MRI at 18 months, it showed multifocal HCC. He had at least 10 bilobar lesions with largest 1.2 centimeter, and many lesions were showing arterial enhancement and venous washout. So he was started on immunotherapy. So the question to Dr. Kulik is, this patient who had, if you look at his pathology report, all favorable features on pathology, clinically he had all favorable features, but unfortunately at 18 months he came with this multifocal HCC. Now, is this surveillance protocol appropriate? Would you do any other surveillance protocol, or this is one such patient who develops recurrence probably because of micrometastasis?
Yeah, so this is one of the speakers in the morning had said, we basically know nothing. Every time you think you understand a disease, you're shocked by something like this. So this is a patient, they had no high risk factors. I would have screened them every 3 months with imaging and AFP. After a year, I would have gone to a year to continue to screen them. In terms of the role of immunotherapy, I think this is very appropriate. There are multiple lesions. The largest was 1.2, so they're very small. This person is outside of the downstaging UNOS protocol, but if there was a significant improvement in those lesions, one could potentially argue for trying to get a upgrade for this patient, although it's very concerning with the number of lesions. Another thing I will say is the AFP had been normal. This person had a colon cancer. You can see AFP go up because of a hepatotoid. When you have mets to the liver, that's more so in patients who have gastric cancer or ovarian. So if you see a high AFP and a liver lesion, also think of liver mets.
Thank you so much. One more case. 59-year-old male referred for evaluation of elevated ALT prior to sleeve gastrectomy. He had metabolic syndrome with elevated BMI of 38, type 2 diabetes, and dyslipidemia. No significant alcohol use history. His ALT is 128. AST was 72. The alkaline phosphatase, bilirubin, and serum albumin were all normal. Platelet count was 212. INR was 1.1. Viral hepatitis panel, autoimmune panel, ferritin ion panel were unremarkable. Ultrasound showed hepatic steatosis. He had an MRE that showed an LSM of 3.8 kilopascal, suggestive of advanced fibrosis. So this patient was cleared for sleeve gastrectomy.
Quick question, which is the AST, Arvin?
ALT was 128, the AST was 72.
Okay, so ALT higher, okay.
The MRE showed an LSM of 3.8, suggestive of advanced fibrosis. So during a sleeve gastrectomy, this is how the liver looked. The surgeon noted cirrhotic appearing liver and biopsy was performed. Biopsy showed MASH NAS score was 5. As per the biopsy, this is bridging fibrosis or F3 fibrosis. So the main question, the reason I brought it out is because we have new treatment for NASH. And this patient, biopsy said F3, but clearly the liver appeared cirrhotic. So would you consider initiating resmetirom in this patient? Question of anyone in the panel?
That nodular liver is scary.
Oh.
You're seeing most of the liver, and the biopsy is 1/25,000th of the liver. And you and I talked about last night, all these 18-gauge needles, which are nearly worthless. You got to get a real biopsy. And the surgeons are in the OR. They might as well get a 14-gauge, right? Get a real tissue. But they don't. They're afraid.
But he had no evidence of significant portal hypertension.
No
so
portal hypertension.
You could argue proceeding with a sleeve gastrectomy. I wouldn't do a gastric bypass on a patient like this, but would encourage a sleeve gastrectomy to try to prevent further development of liver damage.
Yeah, so he did undergo sleeve gastrectomy at the same time. Okay, so that concludes our session. Once again, I thank all our experts for being here today and giving talks. I also request everyone, please reconvene after lunch at 12:30 sharp to start off the functional bowel disorder session with a talk by Dr. Michael Camilleri. Thank you.